Assalamu alaikum, everyone. Bismillahi wassalatu wassalamu alayka ya Rasulallah. But we begin with the name of Allah. Alhamdulillah, we are doing an extra session with this health series at an MCC. We have our Dr. Ismail Khalid Yousaf, who has reached out to us and volunteered to present a very important and a valuable topic that needs to be shed more light upon and just kind of give his insight about headaches in pediatric as well as the teenage group. And Dr. Yousaf is a neurologist by training, and he has recently completed his fellowship, mashallah, and is going to go to practice in Virginia in academics. And he has put a wonderful presentation for us together to listen to and get more knowledge about headaches. And hopefully, inshallah, this will give a base to learn more and to seek more help regarding this issue. So I'll let you go ahead and introduce yourself and then start with your topic, inshallah. And Jazakallahu khair again for volunteering and kind of shedding light and educating the community on this.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Namaduhu wa nasalli ala rasulil kareem. A'udhu billahi minash shaitanir rajim. Assalamu alaikum, everybody. Thank you very much for attending this session. My name is Muhammad Ismail Khalid Yousaf. I go by Yousaf. One of the major reasons of giving this talk is to educate our community, our lovely community, about pediatric and adolescent headaches, why it should be taken seriously, and what impact it has on kids' health, psychosocial health, and socioeconomic impact on parents. So I'll try to make it very beneficial for our community in a way that it's more going to be religious and culturally appropriate. We're going to have some cases, which will be educational cases and some important learning points. So today's goal, we'll talk about types of headaches within the scope of this talk, epidemiology of children's headaches, clinical features of different headaches, what red flags should parents and siblings should be looking for, and then the psychosocial impact, especially on school, sports, and relations, and then the diagnosis and treatment approach. This talk is going to be around 40-45 minutes, and then we can have a discussion if needed. So firstly, remember, headache is an umbrella. And under this umbrella, there are multiple headache types. The most common, which you might hear, are the sinus headaches, tension headaches, and migraine. Cluster is very less likely in kids. The sinus headache you might hear about if a person, adult or kid, has some kind of an infection going on, especially viral. They'll expect some pain around this area, the ethmoids, or the most common is the frontal area. They might have nasal discharge and they might not have nasal discharge. They might have congestion. One of the hallmarks of sinus headaches is that when you bend down, you feel worsening of the headaches. You feel that you have stuffy nose, but you cannot get it out. That's where nasal decongestants come in. Then we'll talk about tension and migraine in detail today. Why this slide is important is to remember that headache is the most important symptom of these manifestations. It's not the only symptom. I always ask my patients who come to me to draw their headache experience, especially children, just to give me an idea what they're experiencing, because children do not have the best words to interpret their feelings. And you'll be surprised every time I do it. Parents are surprised of how much they don't know about it. This is just an example of some of the children with consent I have taken, and what they go through. It's a lot of pain. It's a lot of experience. For example, number 11, kid is experiencing a hammer hitting on the back of his head. Imagine a hammer on the head of an adult. How bad would it be? So a kid experiencing it is even worse than that. Number 10, a kid is experiencing a knife stabbing on her head. At the same time, she feels dizzy and feels like throwing up. That's a lot of things at the same time. They might not be able to express them, but it's important that we need to know that so we can treat appropriately. Important facts and terms which we'll be talking in this talk. First, pediatric is less than 12 years old, and adolescent are 12 to 18 years old. Number two, headache in children and adolescents is the third most common disease-related cause of school absenteeism and can lead to impairment in the quality of life, both in the family and leisure activities. Frequent recurrent headaches, defined as experiencing 1 or more days per week with headache, occur 8 to 30% of children and adolescents. And in addition, patients with, especially adolescents with headache disorders, are at risk of developing mental health disorders in adulthood. Why headache and disparity education is so important? Remember, we live in a society where we unfortunately have funding and research going to certain sectors. So hence disparities in access to care play in gender, socioeconomic, race, and ethnicity, differences in outcomes cannot be ignored. For example, published researches have shown that while Black people and men are less likely to get a diagnosis for their headaches, white children and adolescents are more likely to be prescribed acute medication for primary headache disorders than children of other races. In addition, higher socioeconomic status is associated with higher prevalence of migraine specific drug triptan use and higher likelihood of accessing medical consultation as compared to people with lower socioeconomic status. And more importantly, improving access to care for all children and adolescents with headache disorders with a focus of ensuring equity in access to care should be a top priority for every field. Sparse headache researches on brown-colored ethnicities are done, especially South Asians. So we'll do 3 important educational cases today within the scope of this session. So I want you to meet Hassan. Hassan is a 12-year-old active boy with no significant past medical history. Hassan is known for his excellent academic and athletic performances in school. As you can guess by the picture already, Hassan is working on the computer. He's the power forward of his basketball team, and both his schools and basketball's finals are coming up. Hassan has been working extra hard since the start of the year 2024. Now, this is a very common scenario, and you might be able to easily reflect with your kid's performance. He's working hard, he's good in athletics, he's good in academics, he's very focused. However, Hassan has been complaining of on and off headaches, which started 3 months ago, noticed by his family gradually. These headaches are mostly during the day, around his frontal head, like wearing a band, like a bandana, or like females like to wear a band on top. He feels that sensation. Headaches can last up to 2 to 3 hours, but once a bad one lasted for 4 days. Hassan tries to work through those headaches and still completes his chores and work. But remember, these headaches are still bothering him. Hassan has been able to play basketball, but feels his quality of dribbling and decision making, as you can see in the picture, he's a little off, is not the same. Moreover, his grades in maths and English have dropped. Hassan's mom is worried, obviously, since Hassan has never complained so regularly about headaches before. Hassan's mom is self-treating with acetaminophen, which is known as Tylenol in the market, and then ibuprofen, commonly known as Motrin, with dose written as on the back of the bottles. These headaches would mostly resolve with either of these medications. However, in the last 1.5 months, the headaches have been almost 3 to 4 times a week, which makes almost 14 to 16 times a month. And mom has noticed that both Motrin and Tylenol bottles are finished. Again, a common scenario. That's how you know the chronicity of those headaches is when your medication bottles are done or your capsules are done. Mom is rightly worried that there is something, God forbid, sinister going on in Hassan's brain. He rightly makes a referral to see Hassan's doctor. Hassan comes to us of visibly anxious. He tells me, Dr. Y, I'm not sure how it started. I feel like a dull pressure on my whole front and side of the head. And sometimes dullness moves to the middle of my head. That starts like this, and then it goes on top. I can still play and study with it, but I often have to take medication because it bothers me. Sometimes it comes back on the same day. So the headache is gone, but it's coming back on the same day. I'm sleeping less because I keep thinking about it. That's pretty bothersome. Hassan denies nausea, vomiting, numbness, loss of strength, and waking in the middle of the night. These are all buzzwords which we'll be using again and again during this talk. Nausea, vomiting, numbness, loss of strength, and waking in the middle of the night. Hassan does feel during headache, light bothers him, but the sound does not. Light bothering, also scientifically known as photophobia. Sound does not, so phonophobia is not there. Hassan's exam is completely normal. So, during social history, Hassan, as you can see, is visibly not feeling well and is a little upset as well. He's a little hesitant, but then he states, I'm worried about my finals, doctor. I've had drop grades already. Ahmed, one of his best friends, might score higher than me this time. Hassan denies bullying at school. Further, Hassan, who weighs 65 pounds, states he has been missing lunch. The water intake has decreased from 2.5 bottles to 1.5. He's sleeping 6 hours as compared to 8. So you see the changes that have started to happen over the course of these months. For mom, visibly, some of this information is new. Mom denies any illnesses and trauma leading to headaches. So let's sum this encounter. Excuse me. The summary. We have a 12-year-old active and high-achieving boy excuse me, who has developed new headaches. These headaches are frontal, both sides, dull, and band-like, lasting from a few hours to a few days. This is resolved with over-the-counter use of pain. Excuse me. There's a temporal relationship of headaches in pursuit of academic and athletic excellence. He's expressing peer pressure. He's concerned Ahmed might go up. His academic and athletic performance has been overall affected. His sleep, fluid and food intake is going down, and anxiety of bad results is going up visibly. The only associated symptom with his headache is light sensitivity, photophobia. Mom was not aware of all this information. No red flags, and we'll talk more about it. So this is a very common scenario. Even in my kids, I might see it, that we have a kid who is so high achieving, but suddenly he has been taking extra peer pressure, he has been taking extra work effort, and now his headaches have come, and now he's not doing the best of the job he wants to. headaches. Sorry, I don't know what's going on with my throat right now. So I want you to read this line a little bit and focus on what it means actually. So tension headache is a primary headache disorder, which gives a sensation of tightly band wrapped around your head that puts pressure on your forehead. In children, it's estimated that it counts for 11% and 9% in females. Tension headache has a slight female preponderance of 1.2 ratio to 1, much lower than the 3 ratio 1 in migraine. This is a busy slide. I want you to focus for a moment on this, and then we'll talk more about it. So what I want you to focus is on those yellow lines. Tension headache should not get worse with physical activity. There's no nausea, no vomiting, but it can have either light sensitivity or sound sensitivity. If it becomes more than 15 days for 3 months, it's called chronic tension headache. And that's what Hassan was going towards. Now it's time to actually get it better, because now we have diagnosed it and we have to make sure the chronicity doesn't happen. So what's the treatment for it? It's very simple analgesics. And if needed, counseling, which in school, luckily over here in Austin, I've seen it's very easily available. But there's one caveat to it. That is that if you give analgesics, it can lead to what we call medication overuse headache. Now, what is medication overuse headache? It means that if you give analgesics like NSAIDs, which are ibuprofen, naproxen, and give more than 15 days for 3 months or more, first of all, they will have their own side effects. But more importantly, it can lead to a vicious cycle of what we call medication overuse headache, which is a completely different type of headache. Which means that if Hassan was taking more than 15 days of headache medication, like ibuprofen, or 10 days of acetaminophen for 3 months, on top of tension headache, he will have a new kind of headache, which is called medication overuse headache. And that one is a more tougher to treat than the tension headache. This is a very important information, parents, because you have to make sure that you do not overtreat it as well. Now, let's talk about psychosocial impacts. Exposure to interpersonal violence with abuse or neglect in early age has been posed as a potential trigger of headache in adolescents and adults. In this regard, dysfunctional family relations may influence children and adolescents' ability to cope with recurrent pain. So imagine if a kid and his parents are going through a divorce. Unfortunately, his recuperation mechanisms will be affected. As compared to 3 months ago, he might not be able to recuperate as quickly as he used to be. This is how nature works. This is how the brain works. So at that point, his headaches might exacerbate and might be resistant to treatment as well. Thus, Adverse childhood experiences with moderate to severe stress impact during the first 18 years of life may be negatively and cumulatively associated with chronification. That's why it's important that kids during the first 18 year are in a very safe environment, meaning that parents know what's going on in their lives. Like this mom was not aware of the whole scenario, and it's natural. It will happen to most of the parents, and that's why doctor's appointment, they will know more about what's going on. But when things get out of the hand, when they're not aware of the whole scenario, and after a while, when the fire's in the bush, they got to know it takes that much time to get it better as well. So the moral is the earlier we know, the better we can treat. And then it is mostly expressed by anxiety and mood disorder. So this is um, a very good slide, which I want you guys to screenshot if you want to. And that is the regularity of schedule. How to make sure your schedule is on time. Sleepio.com is a great resource for children 3 to 5 years. 10 to 13 hours of sleep is necessary. 6 to 12 years, 9 to 12 hours. And then teens, 13 plus, 8 to 10 hours. Remember, sleep debt is a real phenomena, which means that every hour you miss during sleep, it will take up to 3 days to neutralize it. And you cannot neutralize with sleeping over the weekends. In fact, you will increase your caloric intake, you will be more irritable, and you might not be making the best of the decisions. 30 minutes a day and 5 days a week of some activity is recommended. And then regular meals, out of which the most important is the breakfast, which should be protein rich within 30 minutes of waking and not skipping meals. Stay hydrated. The most common and easy formula is 1 ounce per kilogram. If your kid weighs 30 pounds, 30 ounces in a day. If your kid weighs 50 pounds, 50 ounces in a day. And then headachereliefguide.com is a great resource as well. You can know more about healthy habits. I'm going to just stay for like 3 seconds so you can take a screenshot if you need to. Same again, lifestyle modifications, stress avoidance, electronic devices, regular exercise, and then avoidance of smoking, alcoholic drinks, and other abuse substances. Now let's talk about screen time. And I know this is a very common topic and how to talk to your kids about it and what are the recommendations. So we'll talk about American Academy of Pediatrics. They recommend no screen time for children under 2-year-old. Exception is video chatting. Kids ages 2 to 5 should have no more than an hour of daily screen time. That's it. They should follow 20-20-20 rule. Every 20 minutes, take a 20-second break and look at an object at least 20 feet away to reduce eye strain. So 20 minutes, they watch something, 20-second break, and then at least 20 feet object is seen so the eye strain is lessened. Adjust display settings. Brightness should be matched the brightness of the room. So whatever the room brightness is, make sure the brightness of that computer or electronic device is the same. And then text size should be increased on devices. Small font leads to more eye strain. Another good rule is the 1-2-10 rule. Between hold your phone, and that's for adults as well. Hold your phone 1 feet away, sit 2 feet away from the computers, and at least 10 feet away from the TV. 1-2-10. Blink more often. Staring at a screen reduces normal blink rates 15 to 20 times per minute by more than half. And then check posture. Believe or not, most of the patients which come, including me, I'm guilty of that. Our posture is one of the main exacerbation factors for our headaches. So we should be sitting like this. The more we slouch our neck muscles, the more they can go into spasm easily. And these nerves talk to our nerves in the brain. And that's how headache is propagated from there as well. Another common question which is asked by parents is, our kid has not started swallowing pills yet. So what's the strategy? How we can help them swallow it? So one of my supervisors actually told this strategy and works great. If you would like to treat pill swallowing, you can do this. Pick up different size sprinkles from grocery store, like Walmart or Target, teeny tiny, slightly bigger, and then goes. And then start practicing with sprinkles. Give a small one, give a bigger one, and then go. The good thing is if it melts in the mouth, good taste. If it does not, that's fine, because these are melting ones. And then once they do it, give them some positive reinforcement, give them some stickers. Now let's talk about our second case. We talked about tension type headaches. Let's talk about another one. So meet Anam. Anam is a 16-year-old girl who actively participates in community volunteering. She and her elder sister have been integral in Ramadan charity drive in their area for many years now. However, since last Ramadan, Anam has started missing school and Ramadan drive because of headaches. Her elder sister believes she's having similar headaches as she experiencing. So elder sister feels that now what Anam is experiencing, she has been experiencing for a while now. Anam describes her headaches as mostly right-sided, but then it hurts in the whole head. They start slowly, and within 1 hour, it's 7/10 in intensity, 10 being the worst headache anybody can experience. The headaches can stay between 2 to 5 hours, but once it stayed for 2 days. The headache is bad enough to stop her work. Now, as compared to Hassan's headache, Hassan was still power throwing it. He was playing basketball, he was playing, he was working, but it bothered him. But for Anam, the headaches are bad enough and disabling enough that she has to stop. She was unable to participate in charity drive in May, as due to her headache, she had to go back and sleep. She likes being in dark room without noise and no movement. Once she wakes up, she feels better. So Anam comes to the clinic and draws a picture to describe her headaches. Let's see what the picture is. So I want you to interpret yourself what you think. I take it as an abstract, but what it seems like that Anam has drawn a brain, which is on a cloud. And then through different lines, she has inferred explosions. So imagine a kid feeling that her brain is on a cloud, which means it might be foggy or lightheaded. And around that lightheaded brain, she is feeling these pounding, explosive sensations. It must be disabling. Anam is brought to the clinic by his mom. She comes to us. Her mom states, Dr. Y, Anam has been having headaches since her menarche, since her menstrual cycle started. That was 4 years back. Initially, they were 2 to 3 times a month. However, in the last year, they have ramped up, sometimes even 6 to 8 times a month, out of which half are severe. Anam states, Doctor, during the headache, I feel I'm dizzy and on a cloud, lightheaded. I want to throw up, but I can't, which means she's having nausea, but she's not vomiting, except only once I've been able to. Light and sound makes me irritable. Sometimes mom's favorite blue candle smell worsens my headaches. I just want to be in bed with lights off and with no one in the room. So see, there's so many associated symptoms with these headaches. However, these are very common. So light bothers her, sound bothers her, smell bothers her, movement bothers her, and more importantly, she's not able to do her work. And these headaches are getting worse over time. And they started with menarche, which means with a change in hormones as there's a preponderance in females. She denies headaches elicited by sneezing, coughing and defecating, which means Valsalva. Anam tells another interesting point. She says, Dr. Vibe, sometimes I know a headache is coming because I see these different zigzag colors coming around. So she has some warning sign that is coming around for headaches. And that's how we recognize headache is coming. They start from the periphery, they slowly become big, and they come in the middle, and then they evolve. I feel blurry, but after 10 minutes, these colors go away and headache comes on. This happens at least 2 to 3 times a month. That's interesting. Dr. Y shows Anam a picture. He's like, is this what you're experiencing? And she says, yes, I can relate to it. Anam, with this picture, which I'm going to show, denies any speaking, sensation, and strength issues. So the only issue she's having is visual. However, she could have also experienced trouble in speaking, trouble in sensation like numbness, tingling, or strength. She might have felt weak. So what was the picture? So these zigzag lines, she was like, exactly, that's what I'm experiencing. These colors, which come from the side, and they're so zigzag, and then they slowly come, and she feels blurry, which you can see in the middle of the vision. Anam then states in her social history, I feel in summers my headaches worsen. I'm drinking enough water, but once I'm out in the sun, I can start having a headache, which means dehydration and heat and humidity are triggers for her headaches. Sometimes I go to bed with a headache and wake up with a headache. What does that mean? That her headache is not being treated properly. That she's going at 10 p.m. with a headache and she's waking up at 8 a.m. with the same headache. It's the same vicious cycle that is going on. It's not breaking. My sister went through a big surgery 3 months ago, and I'm taking of her chores. So she has extra pressure on herself. So she's not sleeping properly. Headache is not breaking, and she's doing extra work, which is more burden on her brain right now. Since I've missed school, my homework keeps piling. This is a part of the vicious cycle. She's doing extra work, the headaches are bothering her, homework is bothering her, and now exams might be on the corner. So see, the kid might not be suggesting a lot of things, but when you go into the social history, the headache is the tip of the iceberg. There's a base to uncover. Mom states her headaches worsen during her menstrual days. So during menstrual days, what happens in females is that estrogen, that you might have heard as one of the major hormones, drops. That's why preponderance of these headaches, which we're going to talk about, is more in females as compared to males. Anam's physical and eye exam is completely normal. So this is classic migraine with and without aura. So to summarize it, Anam, a 16-year-old female who started having headaches when she was 12, when her menstrual cycle started, and then slowly it ramped up. It ramped up because she has more pressure on her now. On top of it, during menstrual cycle, she has a preponderance to get it worse. She's taking a lot of care of her sister, chores, her school is getting messed due to headaches, and she's in top of a vicious cycle, and she does not know how to break it. The worst part of it is that she's going to bed with the headache, and she's waking up. Even the sleep is not helping her. This incident is very common. At least 1/3 of migraine occur in childhood or adolescence. The majority of children and adolescents with migraine will continue to have throughout their life. 50% will persist with migraine, 25% tension, and 25 might outgrow it. But how many outgrow, we do not know. And what's the preponderance and what are the signs that they might outgrow? We don't know yet. A very easy way to check is OPQRST. Everybody knows alphabet, so it's very easy. OPQRST. Onset, when did it start? Provocation, what worsens it? Quality, dull, pounding, throbbing. Radiation, where does it go? severity, how bad it is it disabling, and time, how long does it last? So what's the difference between a headache and a migraine? So remember, migraine is a neurovascular phenomena. It's a neurological phenomena, which is usually unilateral but bilateral in kids with associated symptoms, which you just heard about: aura, photosensitivity, light sensitivity, osmophobia, smell sensitivity, and headache. And headache is the most important symptom because this is experienced by most of them. Can migraine happen without headache? Yes, aura can happen, and we'll talk more about it. So migraine, there are four stages. If you have seen Prestige, the movie, they say there are four stages to the magic. Unlike my magic, this is something very disabling. So the first is prodrome. So parents might experience that before the headache starts, much before 24 to 48 hours, the kid might have constipation, mood changes, depression to euphoria, food cravings. They will be eating more junk food. Neck stiffness. They will say, we are having spasm or we can't move our neck properly. Increased urination. They might be going to urine more often at night. Fluid retention. You might, some patients have, parents have said that we've seen some baggy fluid like retaining below their eyes. And after like 12, 24 hours or 48 hours, we've seen a sudden attack of headache. And then frequent yawning is the most common, which I've heard. Stage two is the aura. So first stage started 48 to 24 hours ago. Then 5 to 10 minutes or even 60 minutes before the headache comes in, you see the aura. And aura, as in this picture, are these color sensation. This is the visual aura, which happens in 90% people. It's a complex neurological phenomenon. Minimum 5 minutes can be up to 60 minutes. People see various shapes, bright spots, flashes of light. Some people also complain of vision loss, which is a red flag. And pins and needle sensation arm or leg, or weakness on one side of the body. So why this education is so important? Because each of them has repercussions if your kid is experiencing an aura. And why repercussions are important? Because in females, if a female is experiencing migraine with aura, oral contraceptive pills like estrogen and progesterone can only be used low dose. The reason is migraine with aura in female, the chances of stroke double fold. And then the third is the attack, the headache itself. It can last from 4 to 72 hours in adults. However, 2 to 72 hours in kids. If it's above 72 hours, we use the term status migrainosus, and that's the time that you need to tell your doctor or take to the ER because you need to break that cycle. It can worsen after that. During a migraine, you might have pain, one side or both sides, throbbing or pulsating, sensitive to light, sound, and sometimes smell and touch, and nausea and vomiting. And the fourth stage and the last stage is the postdrome. So the postdrome stage is when patient feels drained, fatigued. You might have seen yourself if you experience migraine or your kids that once their headache is gone, they might be like, just leave us alone. We need to just recuperate ourselves, just like a viral illness, because the brain is drained now. It's trying to reestablish itself. It's also called migraine hangover. So again, 4 stages. I can just tell you that prodrome is the hottest stage right now, that if parents start to know the kid is going to have a headache and they know the prodrome signs, they start giving the medication straight away so they can hit it. And that's where all the research is being done. An important aspect is that migraine is a genetic condition. 70% people who have migraine have some kind of family preponderance. We have more than 171 genes which are connected to the risk of migraine. If one parent has migraine, there's a 50% chance the kid will have it. If both parents have it, 75% chance. Since it is brought by both neuronal and vascular, which means blood vessels, genetic factors, it has been strongly thought to be a neurovascular disorder. Now, another interesting topic that is not talked a lot is episodic syndromes associated with migraine. So what are these? Basically, there are some symptoms which happen in early childhood, which might be associated with migraine or preponderance, and it's important to know about them. The first is abdominal migraine. If your kid is having recurrent bouts of pain in abdomen, and then GI does not know exactly what's going on, or other things have been ruled out, nausea, vomiting, anorexia, or pallor is happening, he might be actually having abdominal migraine. The important thing is he should not have headache with it. If it's headache, then it's migraine without aura. Another thing, if paroxysmal torticollis, if kids are born with a spasm on the neck, benign paroxysmal vertigo, if kid has these spells in which he spins, he tells that I'm internally spinning or the world is spinning. And then cyclic vomiting syndrome, which is more common, which is recurrent bouts of a lot of vomiting attacks. And they're predictable within 10 days. And then GI disturbances. I know these are tough terms, but I want you to remember them just if you hear about it, because then they need to be treated. If they're not treated, the migraine preponderance will increase anyhow, but these are more disabling. These will lead to school absenteeism and decrease athletic and academic performance. On top, loss of friends, because kids would not like to have friends who are always in pain. It's a natural phenomenon, unfortunately. But we need to make the quality of life better. So, treatments of migraine. We are in an exciting era when it comes to migraine treatments. We have done a lot of research and we know how to treat it. We don't know how to cure it, but we know how to treat it better. The next step is taken from American Academy of Neurology and American Headache Society journals, Continuum, and guidelines. So the principles are very straightforward, and it goes to both adults and children. First, a rapid and complete relief of pain and any associated symptoms that causes greater impairment than the head pain. Second, prompt return to function and reduction in disability. Thirdly, the first dose should be effective enough that you don't need of a return dose or the headache should not come back. And the last two, which are important for me and you at the same time, is that minimal side effect, burden, and cost effectiveness. So why rapid and complete relief of pain is so important, especially for parents? Evidence has showed that a partial response to acute treatment is associated with lower patient satisfaction, higher risk of headache chronicity, and higher migraine burden, which means the disability will worsen if you only have a partial relief. Another important aspect is nausea. Do not ignore this. If your kid is suffering from nausea with headache, it needs to be treated. It's as important as headache, which means nausea-specific medication needs to be prescribed, and you have to tell your doctor about that. Nausea accompanies 70% of migraine attacks. And then frequent nausea is associated with increased risk of chronic migraine. And on top of that, if nausea is there, the patient might not take the pill or the medication that you're prescribing because they're anorexic, they don't want to take it, they'll feel bad about it. So we have to come up with a strategy that we curb the nausea, at the same time we curb the headache. So what are your options when it comes to nausea curbing? So your doctor might prescribe what we call promethazine or prochlorperazine suppositories if the patient is vomiting. Because if the patient is vomiting so much, he cannot take the pill inside. At that point, the resort would be a suppository. Then metoclopramide or pompazine or Reglan, you might have heard them, are very common. But the most common is the Zofran, the medication itself, which is a similar principle which acts on serotonin receptors, and it has the least side effects that we know of. Talking about NSAIDs, which are easily available in the market, the top are ibuprofen, naproxen, diclofenac is prescribed now. The common principle we headache doctors use is 10 mg per kilogram first line, and ibuprofen and naproxen both are used. It has been shown that NSAIDs are superior to placebo, which is nothing, and acetaminophen, which is Tylenol. So our first line of recommendation is, unless the parent says that the headache goes away with Tylenol, we'd like NSAIDs to be given since it has more evidence. Although pediatric specific evidence for non-combination NSAID is not available, sumatriptan, which is the migraine specific drug and can only be prescribed by the doctors and should not be taken more than 9 times a month, in combination with naproxen, has been shown to be the most effective treatment. So for kids, we go again, mg per kg, that's how we do it. If a kid is above 50 kilograms, we like to do 500 milligrams of naproxen with sumatriptan to give at the same time at once if there is moderate to severe headache. And supposedly, if the headache doesn't go away, then you give it after 2 hours again, only the sumatriptan. So there are so many triptans available in the market, and luckily some of them are approved for kids. Rizatriptan, also known as Maxalt, is FDA approved for 6 and above. Zomitriptan, elmotriptan for 12 and above, and sumatriptan and naproxen combination for 12. You don't need to remember this. This is what your doctor will prescribe, but it's just that you are familiar of what is available and what are your options. Another interesting thing that has come up, and I'm a big fan of it, is non-invasive neuromodulation, which means you don't take pills. This device is an REN, remote electrical neuromodulation device. It has been FDA cleared for kids as well. So what this device is, that it is a band like on top of your arm, and it comes in an app. So if you're having a migraine attack, you through the app turn on the device, it gives some electrical stimuli, like a tingling feeling, which activates the nerve receptors. So these nerve receptors tell the brain, hey, something is going on. There's some pain. Brain kind of fools itself and activates the neuroinhibitory pathways to decrease the pain, to decrease this pain. But at the same time, because the pathways are activated, it also decreases the migraine pain. It's a great device. It's still prescribed. It costs around $100 per month. Initially $49 and then $100, 18 treatments. It's also brand name by Neurologist. But my patients really have benefited because you don't take a pill, plus it's a band which goes on top of it, and you can take it everywhere. First of all, it's hidden. Patients don't need to show it. And then whatever activity you're doing, you can continue on that and you can get treatment at the same time as well. The other ones are single pulse transcranial magnetic stimulation and non-invasive vagus nerve. And my cough is back as well. So what are the preventive options? We have multiple preventive options, and luckily, most of them work. The first line, which we do in kids, are nutraceuticals, vitamins, coenzyme Q10, magnesium, riboflavin, vitamin D. And if these do not work, then we go to pharmacological, like amitriptyline, propanol, topiramate. You don't need to remember these. The doctor will prescribe them. But what you need to remember is how they will be used for you. Let's suppose if a kid has hypertension, high blood pressure, they might give a drug called candesartan, excuse me, which is used for hypertension and headaches. If there's obesity, topiramate, headache, and also goes for weight loss. There's depression, insomnia, amitriptyline, which helps both. And then most often asked is Botox. Botox is not FDA approved for kids. However, we do use it off-label in kids under 18. They're 31 point injections only for chronic migraine. You only get it once in 3 months. Excellent results. We try it for 6 months, and if it's not working, then we stop it. But very good results with Botox. So what are the learning points? All children for headache disorders, primary headache disorders, should be screened for anxiety and depression symptoms. Asking children to draw a picture is very helpful. Given the prevalence of adverse childhood experiences and trauma among children, clinicians should screen for these experiences and engage in trauma-informed care with patients. And that's probably when even parents would know something is going on. Our last case is a little serious than the last two. Meet Amir. And again, this is a rare case, but I want you to know about it because this is the most something that parents always are very concerned about. Amir is a 9-year boy with no significant past history, but worsening of his headaches. Headaches started when he was 7. He's 9 now. But in the last 1 year, they have really increased. Since school started 2 weeks ago, he has complained of almost daily headache, and they are more intense now, 7, 8, but 10. So remember, the headaches started way back, but they have really increased now to a level that is almost daily. Severe days are almost daily. So there's a change going on. Mom denies any precipitating factors. She's not sure of it. As you can see, Amr is not feeling well. Amr states, my headaches can start at any time and usually are on the back side of the head. It then moves forward to my eyes and then my whole head hurts. Pain can last many days. I feel pressure all over my head. I've stopped playing baseball because when I bend over to pick up the ball, my head hurts. I also have right arm pain that comes and goes. I feel that my right arm is getting weaker than the left. Mom adds, however, in the last 3 weeks, he has thrown up multiple times, 4 to 5 times, especially after waking at night, complaining of headaches. So these signs, as you can tell, are abnormal. There's something going on. He's having weakness, numbness. He's waking in the middle of the night. He's throwing up. And why I'm putting all these points is just for you to know that what are the red flags in a headache that we need to know about our children. I ask, is there anything different about these headaches than the ones you had a month back? He says, these headaches are in my whole head. They don't stop and hurt more. Mom abruptly says, school has mentioned that on a couple of occasions, he has fallen or hit things. Dad adds, I've also noticed that when he wakes up, sometimes his left eye looks lazy for 10 to 15 minutes. He does not report any autonomic symptoms. He does not report any aura symptoms. So as you can tell, this is a very serious situation going on. Amir in the last 3 to 4 weeks has really gone down. This change started a couple of months ago, but in 3 weeks, he has thrown up. He's waking in the middle of the night. He's feeling numb. He's feeling weak. So this is an emergency. Amir was sent to the ER because his exam showed neurodeficits in accordance to history's red flags. Amir was diagnosed with a brain tumor. Luckily, at right time. Recurrent waking from headaches with or without vomiting and focal deficits demand urgent workup to rule out primary and secondary causes. Amir's headaches resolved after surgery. He is much better now. Common question then. Does our child need MRI or CT scan or labs for headaches? And the answer is most children and adolescents presenting with headache and no red flags do not require any labs. They do not require any imaging because for tension headache and migraine in the primary orders, we do not do this. We do not put extra burden on the patient when we know the diagnosis is clear. And that's why history and physical examination in headache is the most important component. We like to go very slow and very deep into the history, especially from parents and social history at the same time. This includes most of migraine and tension type headache population. So another last question, which I'll talk about is when to take the kid to the ER. What are the red flags for the parents? There's severe and sudden onset headache. Let's suppose if Amir had told Dad, last 10 minutes, I'm having one of the worst headaches of my life. Out of nowhere, it started. That's the time to go to the ER. Very early onset of headache. In preschool children, if let's suppose it's a 3-year-old kiddo and his headache comes out of the blue and he's complaining of headache and you're not sure what's going on, you need to take to the ER or book a quick appointment. If he has red flags, you have to take to the ER. Migraine, the youngest patient I've seen with migraine is 2 years old and 6 months. So you can have migraine at that time too. But in preschool children, our threshold is very low because it's more tumors are more common in them than the others. Focal neurological signs, as Amir had, balance issues, cognitive impairment, fogginess, weakness, important signs, which should be known. Early morning headache, that's not normal. Vomiting in the morning, that's not normal. Pain disturbing sleep and headache worsened by cough or Valsalva. Sneezing, coughing, whooping. Headache awakening the child from sleep or consistently occurring first thing in the morning. Because what happens is that these sinister things can increase the pressure in the brain. So when you sleep, the pressure builds up. And when you wake up, that pressure gives you that headache and wakes you up. And then a thing which is very underrepresented is obstructive sleep apnea. If your kid is snoring and gasping your air, or your family has that, you need to tell your doctor because then a sleep study has to be done. Other red flags include accelerated course, change in characteristics over weeks or days, just like Ahmed. Post-traumatic headache. If a kid had fallen down, hit something, and after straight away he has headaches, you need to make sure so there is no bleed in the brain. Headache associated with personality or behavior changes. That is again not normal. We have to rule out infection or any autoimmune process going on. And then malaise and fever are common symptoms of signs of infection, especially to rule out meningitis and encephalitis. However, remember, headache with fever is due to infection of our upper respiratory tract. That's the most common, like cough, cold, sinusitis, and that could cause it as well. We call it headache associated with viral symptoms. But what the red flag is, when there is neck stiffness, you have change in behavior, which could be a part of neurological deficits, and the kid is not being himself. The most common thing which we hear from parents is that he's not the same he was 2 days ago. He's a different person. That's the time that you need to get it out to get to the ER and make sure he's not having meningitis and encephalitis. And another thing is extra malaise. If the kid is just sleeping and sleeping for long times, that's another fact that we need to rule out anything sinister going on. So conclusion, headache disorders are very prevalent in kids. Working towards broader and more equitable access to a diagnosis and evidence-based care for children and adolescents with headache not only will likely reduce the burden of headache disorders, but also be a significant potential to contribute to reduced burden of disease in their adulthood. Listen to your child and don't ignore the symptoms. Headache might be a stigma and taboo, but your kids might not be lying. Their symptoms, as early as we can get them, we need to treat them. So they're better academically, athletically, and their quality of life is improved. For that purpose, We love to do advocacy. Advocacy at highest orders is important. I go to Capitol Hill, we talk to the senators and congressmen about the funding, especially for pediatric adult headache is needed. So we have better research and we know how to treat them better. Luckily, we have podiums where we can do, and if they're migrant patients, they can reach out and I can tell them they can represent Texas. They can go over there and tell their story so they know why the funding is so important. This year, we were trying our best to advocate for 3 bills. One of them has passed. We are trying one bill, which is basically we're trying that insurance companies do not give their priority drug. Our priority drug is prescribed as first line as compared to theirs. Thank you very much. Jazakallah. If you have any questions, please let me know.
Jazakallah khair for that lecture. Sorry. Mashallah, it was very informative. Yes, a lot of information right now, but just you can go over it again, see a lot of the terminology, yes, was medical, but it is more for the understanding. And when you go to your doctors, see them and try to get more help, inshallah, this will help you understand this better. The goal is mainly to, what I understand, is to educate people that, hey, headaches are not just normal, quote unquote, it's not normal to have a headache. And if you are having a certain kind of headache, headaches are very different one from the other. There are a lot of causes of it, as you have discussed already. And these are just, as you would say, the tip of the iceberg. There could be even many more in details. But the most important takeaway points is like, differentiate when to go see somebody, seek help, write down your symptoms, see what's causing it. Yes, you can try the home remedies, drink a lot of fluids, hydrate yourself. I was very impressed with that 1 ounce per pound. Mashallah, I learned that today. And that's nice too for anybody, to kind of keep in mind, especially with children. You're always wondering what should they be drinking? So that is very good. Inshallah, I hope we learned a lot. And just Tylenol and ibuprofen, yes, but see how much you're using, because medications do worsen them. So, and even the sinus headaches, I don't know if we talked about that, back home, we do use a lot of the nasal drops, especially Afrin, which is here, and those worsen your congestion. And not things that you want to just medicate yourself without seeking advice. So it is better to consult your doctors, discuss with them, change your lifestyle. Inshallah, a lot of it can be treated with lifestyle changes, and we hope that this encourages everybody to live a healthy lifestyle, and inshallah seek the attention that you need and help you all. Jazakallah khair again.
Absolutely, absolutely. Sorry for my throat. It was acting a little weird, which
No, it's
not
okay.
expected. But yes, my goal today was to keep this as in repertoire that if your kid is having headache, or for education, you know where to go, see the video, try to differentiate, especially the red flags. That's what parents are more worried about. We'll be worried about. So you can just go and see what symptoms they're experiencing and what medication options you should be informed about. So you can go and talk to them about it as well and what to expect. Because the biggest question is always the expectation, what the expectation from the doctor would be, especially a headache doctor.
Yeah, absolutely. And then I do like that you mentioned the sleep apnea, so common, in
Very
children,
important.
it's very, very important, because we see our kids snoring. Sometimes, it's their tonsils, their adenoids, they're not
Yeah.
sleeping well, they're not getting enough rest. That's causing a lot of problem. As adults, I know, because I'm a primary practitioner, I know I see that very commonly. People ignore their sleep apnea for so many years until it has really done so much damage. So subhanallah, it's very important to recognize these little things that we can change very easily with not even medications, but just interventions which can change them completely. So jazakallah khair. With this, we conclude the session today, and we will see you all next month, inshallah, in person, as well as whoever wants to join in online. We'll be talking about eating disorders next time and having some demonstrations about mindful eating, inshallah. So, and we have very our therapists from our community who are going to, inshallah, talk about that. So, Jazakallah khair. We'll conclude with a dua. سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك. Jazakallah khair again, doctor.
Thank you.
Thank you.